Hello everyone. Welcome back to this series of lectures in rheumatology. Today we'll be starting off with a very important topic, systemic lupus erythematosus. So let's begin. So what is SLE? So SLE is basically a multi-system autoimmune disorder. Okay, so this is a multi-system disorder of autoimmune etiology. Characterized by what? Characterized by antigen-antibody complex deposition in various organs. Okay, so systemic lupus erythematosus is a multi-system autoimmune disorder characterized by autoimmune antigen-antibody complex deposition in various organs. Okay, so in whom is it most commonly seen? So when we look at the epidemiology, it is more common in females more than males. And the very famous number that you have to remember is 9:1 ratio. So it's found in a 9:1 ratio. So whenever you think of this number 9:1, remember that there are a lot of other rheumatological disorders which are more common in females more than males in the same 9:1 ratio. So what are the other disorders? So it's just a refresher to remember the other disorders which are found in a 9:1 ratio, female to male predominance. So that includes MCTD, autoimmune hepatitis and SLE. Okay, so these are the other disorders. Also we have Sjogren's syndrome. So remember that SLE is more common in females than in males, found in a 9:1 ratio, and it's usually seen in the age group of around 20 to 45 years, and sometimes you can even find it in the younger age group. As far as the twins are concerned, there is a more than 40% concordance. Okay, so if one twin has it, the probability that the other twin will have it is more than 40%. Okay, so when we speak about the prognosis, male SLE has the worst prognosis. Male SLEs have the worst prognosis, and postmenopausal women usually have a better prognosis. Okay, so this is about the epidemiology. And in whom, what sort of patients is it seen? It is more common in Asians and Hispanics. Okay, so it's more common in Asians and Hispanics, which is basically the non-Caucasian population. Alright, clear. So let us look at some of the etiologies for SLE. So we know that SLE is an autoimmune disorder, but there should be some trigger which causes this autoimmunity, right? So there are genetic as well as environmental factors which act as triggers for this SLE. So when you speak about just genetic factors, we speak about HLA and non-HLA mediated factors. So the HLA factors that you have to remember when we speak about the etiology of SLE, it is HLA-DR2 and HLA-DR3. Okay, so HLA-DR2, HLA-DR3 are the most important risk factors. When it comes to the non-HLA mediated genetic factors, always remember early complement deficiencies. C1q more than C2 more than C4. C1q, C2, C4. Early complement deficiencies predisposed to this disorder, which is SLE. Then presence of an extra X chromosome, IRAC gene mutation. So you have this IRAC gene which is present on the X chromosome, and extra X chromosome, IRAC gene mutation. And the other very important gene that you have to remember is the TREX gene. Okay, so when you speak about genetic factors, remember HLA-DR2, DR3, early complement deficiencies, IRAC gene and TREX gene. And when we speak about the environmental risk factors for SLE, remember OC pill use, hormone replacement therapy in ladies. Then exposure to UVB rays. Then Epstein-Barr virus. The only viral etiology is Epstein-Barr virus, silicosis, vitamin D deficiency, smoking. So all of these are important environmental risk factors for the development of SLE. OC pill use, hormone replacement therapy, UVB rays, Epstein-Barr virus, silicosis, vitamin D deficiency and smoking. So let us understand the pathogenesis of SLE. So just now we have learnt about the predisposing factors, right? So let's just recollect that. Early complement deficiencies, TREX gene mutations, these mutations affect the DNA degradation. So this is your genetic factors. And what are the HLA genes? HLA-DR2 and HLA-DR3, right? So apart from this, there can be environmental factors which includes UV light, smoking, silicosis, EBV infection, and it's more common in females, right? So this is about the genetic and environmental factors. There can also be certain mutations which affect the epigenetics. Epigenetics basically means the actual genetic structure which is responsible for the production of proteins is not affected, but you have the other surrounding regions which can be affected, which is going to modify the activity of the final gene. So this includes hypomethylation of DNA and histone modifications, microRNA affecting the gene expression. So these are the epigenetic factors. Okay. So all of these factors form as predisposing factors. So either the individual is genetically predisposed, or in a genetically predisposed individual, if you have an environmental trigger, then you can have SLE, right? So what happens once these factors are activated? The key thing that you have to remember is that there is an abnormal immune response, or what we call as immune dysregulation. The word is immune dysregulation. Okay, so there is an abnormal immune response. So the normal immunity is going to help fight external pathogens, but here there is a dysregulated immunity which is going to fight against our own cells. Okay, fine. So there is an immune dysregulation, and this immune dysregulation results in excessive activation of B cells and T cells. These B cells mature into something called as plasmacytoid dendritic cells. Okay, so this is the next important word that you have to remember is plasmacytoid dendritic cells. Okay, so immune dysregulation results in excessive formation of this plasmacytoid dendritic cells. So this results in defective apoptosis. So what is the meaning of apoptosis? We have learnt in pathology that apoptosis means programmed cell death. So usually a normal cell, once it finishes its cell cycle, it is going to undergo a programmed cell death, and this is what we call as apoptosis. But here the apoptosis is also defective, and hence the immune system is going to result in a defective apoptosis. Okay, fine. So in addition to this, there can be early complement deficiencies, and these early complement deficiencies is also going to cause immune dysregulation, right? So this is what we are seeing here. So the first and the most important cell is your dendritic cell, which results in excessive activation of T cells and B cells and resulting in plasmacytoid dendritic cells. This plasmacytoid dendritic cells is the one which is going to cause your pathogenic signature cytokine. So the pathogenic signature in your SLE is the production of one particular cytokine which is called as interferon alpha. Okay, so very important. So this immune dysregulation results in excessive formation of the key pathogenic cytokine which is interferon alpha, and also results in the formation of various autoantibodies and immune complexes. Okay, so this interferon alpha is going to form a lot of antigen antibody complexes, and it goes and gets deposited in different organs of the body. Okay, so finally this results in inflammation and it results in damage. It affects the kidneys, it affects the CNS, it affects the heart, skin, right? So this is what is the basic pathogenesis. So you have understood what are the predisposing factors, the risk factors. So remember certain keywords in the pathogenesis of SLE. So there is immune dysregulation, excessive production of plasmacytoid dendritic T cells, defective apoptosis, and the hallmark signature cytokine is interferon alpha. Okay. So this is about the pathogenesis of SLE in a nutshell. So how do you diagnose systemic lupus erythematosus. So before we move on to the diagnosis, let us understand the basics of diagnosis of your SLE. So the one and the most important test which everyone has heard of is your ANA. Okay, so this basically stands for anti-nuclear antibodies. Okay, so the basic test is that, so we know that the basic pathophysiology is that there are immune complexes which are targeted against our own cells, right? It can be cells of the kidney, it can be cells of the RBC, it can be cells of the CNS, right? It can be against neurons. So the aim of the diagnosis of SLE is you will have to diagnose these antibodies. So that is how you come upon this ANA, which is your anti-nuclear antibodies. The technique that is used for this diagnosis is a indirect immunofluorescence technique. Indirect immunofluorescence, or ANA by IF. That is the gold standard or the best way to detect your ANA in individuals. Okay. So how do you do this testing? So the substrate that we use is called as the HEP2 cell lines. HEP2 cell lines is basically derived from a human epidermal tumor. Okay, so these cell lines are derived from basically a tumor which basically keeps on proliferating. This means that these cells have a infinite proliferative potential. So these cells are the one which basically form the base on which you do your ANA testing. Okay, fine. So this substrate is taken and then you take the patient's serum. Okay, so you put a slide with the substrate which basically comprises of your HEP2 cells, and you take the patient's serum and you place it on the slide. Now, if the patient has autoantibodies, what is it going to target? It is going to target the nucleus of these HEP2 cells. Okay, so if the patient has autoantibodies, the antibodies are going to target the nucleus of these HEP2 cells. Right, so that is when you are going to get a reaction and you are going to get a positive result. So this is how you are going to diagnose the autoantibodies. This is the basic crux of the matter. So you take the substrate, you take the patient's serum, and then you will add a fluorescent labeled antibody to diagnose these antibodies which are going to go and bind to the nuclei. Right, so there is going to be fluorescent labeled antibodies. Let us understand that these are fluorescent labeled antibodies, and these are going to go and diagnose what? The antibodies to the HEP2 cells. So this is the HEP2 cell, right? So once they detect these antibodies, so there is an antibody to the antibody which is fluorescently tagged, then you will have a diffuse fluorescence under the fluorescence microscope, right? So this is the basic method by which you diagnose your ANA, right? I hope you have understood that. Now, the report is usually in the form of dilution. So if a higher dilution is required to diagnose this, or you put the serum and you keep on diluting the patient's serum and the fluorescence is there even at higher dilution, what does that mean? It means that the autoantibodies are present in a higher concentration. So higher the dilution, greater the amount of the anti-nuclear antibodies. Okay, so when do you say that the ANA is considered to be significant? So if the titers are more than 1:80, then it is considered to be significant. Okay, so this is how you diagnose your anti-nuclear antibodies. Okay, so anti-nuclear antibodies is basically ANA testing is the basics by which you try and identify if autoantibodies are present in a person or not. And the technique that you use is the indirect immunofluorescence. And what is the substrate? It is usually the HEP2 cell lines. Apart from this, mouse kidney, mouse liver was also being used, but currently the gold standard that we use is the HEP2 cell lines. Fine. So now you have got a positive ANA. Okay, you have got a positive ANA. Then when will you consider it to be clinically significant and a high probability of having an autoimmune disease? So this can be depending upon if it is a low titer positivity, which is less than 1:80 or around 1:80, then this can be seen even in normal healthy individuals, right? This can be seen even in normal healthy individuals. So when will you consider, or when will there be a high suspicion of an autoimmune disorder? When the titers are more than 1:160. So if the titers are more than 1:160, then there is a high probability that the patient is going to have an autoimmune disorder. Okay, so in healthy patients, up to 20 to 30% of normal population can also have a positive ANA. Very, very important point, because many a times we see a positive ANA and attribute all of the patient's symptoms to an underlying autoimmune disease like an SLE. What do you mean by that? The meaning is, if you pick up this individual with a suspected autoimmune disorder and you're planning to do an ANA for him, then there is a 100% probability that this patient will have a positive ANA titer. What are those group of disorders? Remember, only 3 disorders: drug-induced lupus, MCTD, which is your mixed connective tissue disorders, and autoimmune hepatitis. Very, very important point. These are the 3 disorders which have 100% ANA positivity. That means if there is a patient of autoimmune hepatitis, you diagnose him with autoimmune hepatitis, there is a 100% probability that his ANA is going to come positive. Okay, fine. Then 95% of the individuals with systemic sclerosis will have ANA positivity, and ANA positivity can be found in other autoimmune disorders like myositis, Sjogren's, and APS. So 40 to 80% of the individuals with myositis, Sjogren's syndrome, or APS is going to have ANA positivity, and in rheumatoid arthritis and other non-rheumatological disorders like Graves' disease, multiple sclerosis, also you can have ANA positivity in 30 to 50% of the individuals. So what I would like you to take away from this slide is that all ANA positives are not SLE. Okay, and ANA can be positive in 20 to 30% of the normal population. Okay, and the other conditions where ANA is positive, remember 100% positivity, remember only 3 diseases: drug-induced lupus, mixed connective tissue disorder, and autoimmune hepatitis. And lot of other autoimmune disorders can also have ANA positive. Okay, so this is about the basics of ANA, which you have to learn before you go on to learn about the diagnosis of SLE. So whenever we speak about this antinuclear antibody, it's not only the titers which you have to look at, you also have to look at the patterns of ANA. What is this pattern specifically referred to? It is the pattern of fluorescence. Under the fluorescent microscope, the ANA can be in different patterns, and that is also something which helps in clinching the diagnosis. Okay, so let us look at the different patterns. The first pattern of staining under the fluorescence microscope, can you see that if each circle is a Hep2 cell line, you can see that there is a homogeneous staining, right? So this is called as the homogeneous pattern of ANA. So the first pattern is the homogeneous pattern, and this occurs due to the presence of what antibodies? The antibody is a dsDNA. Okay, the antibody is a dsDNA. It can also be associated with which other antibody? It can be associated with the anti-histone antibody, right? So dsDNA and anti-histone can result in a homogeneous staining, and this homogeneous pattern is the most common pattern which is seen in SLE. Okay, so this is the most common pattern seen in SLE. Second, you can see that within the nuclei, you can find small dots, and this is what we call as the speckled appearance. This is called as the speckled appearance. So speckled appearance is not specific to SLE. It can be found in a variety of autoimmune disorders, right? So the list of antibodies which are associated with a speckled pattern of staining is your anti-ROLA, which is seen in your Sjogren's syndrome. Then you have RNP and anti-Smith. Okay, so anti-Smith, RNP and anti-ROLA are associated with a speckled appearance. Alright, and the presence of anti-Smith antibody is the most specific antibody to SLE. Okay, it is the most specific antibody to SLE. Okay, so remember, we are not talking about the most specific pattern. Most specific pattern is different. Most specific antibody is different. Most common pattern is different. Most common pattern is a homogeneous staining. Most specific antibody to SLE is anti-Smith. But most specific pattern to SLE is different, that we will be looking at. Then the third pattern of ANA will be, you can see that there are mitotic spindles and only they will have a fluorescence, and this is what we call as the centromere pattern. This is what we call as the centromere pattern, which is seen in limited systemic sclerosis, limited scleroderma. Then fourth, you will have a fluorescence only around the rim, and this is called as the rim pattern, which is associated again with dsDNA, and this is the most specific pattern in SLE. Okay, so this is the most specific pattern in SLE. Then the last type of staining is the anti-nucleolar pattern. Okay, so this is the nucleolar pattern, which is associated with SCL70, fibrillary RNA polymerase 3. All of these are seen in systemic sclerosis. Okay, so this is about the 5 patterns that we should be aware of. So the most common is the homogeneous staining, and the non-specific one is a speckled pattern. In systemic sclerosis, you find 2 types. You can have a nucleolar pattern, centrometric pattern. Centrometric pattern is seen in limited systemic sclerosis, and nucleolar pattern is seen in diffuse systemic sclerosis. Rim pattern is associated with dsDNA, which is the most specific type of pattern. Most specific antibody is the anti-Smith antibody. So let us look at the same thing, which is a real-time photograph. So can you see in the first image that there is a homogeneous staining of the nucleus? So this is the homogeneous pattern. Here can you see that within the nucleus itself you have the nucleoli which gets stained like this. So this is the nucleolar pattern. Can you see the fluorescence is present only within inside the cell? Then this is more clear here. You can see that only the peripheries, the surrounding is getting highlighted. So that is the rim pattern of staining. Okay. Then here can you see it's not very clear, but you can see that there are fluorescence somewhere only in the center like this. Okay, you can see that this way. So this is your centrometric pattern. Under the speckled, it's not very important, but you can have a coarse speckling and a fine speckling. So if you enlarge here, you can see that few dots only are getting highlighted. Okay, so this is how your different patterns of ANA staining appear. So always try and remember about how do you diagnose your SLE. For you will have to know about the ANA patterns. You also have to know about the ANA dilutions. This is your ANA with your indirect immunofluorescence technique. Alright, clear? Fine. So now once you have got an ANA positivity, what is the next step that you want to do, especially in the diagnosis of an connective tissue disorder or SLE, is that once you have got an ANA and you have found a pattern and you feel that it is significant because of the titer dilution more than 160, maybe 1 in 240 and so on and so forth, then you may have to do a immunoblot. You have to do a immunoblot. The immunoblot or an ENA, which is an extended ANA type of pattern. So this immunoblot or ENA gives you the list of other antibodies which are positive, and therefore you can find out which antibodies are specific to which disease and you can diagnose the underlying autoimmune condition. Alright, clear? So now let us look at the various autoantibodies which can be found in SLE. Okay, so the first is your anti-nuclear antibodies or your ANA. So this is found in 98%. So does that mean that what about the 2% which is left behind? So does that mean that 2% can be ANA negative in SLE? Yes, so there is an entity which is called as ANA negative lupus. Okay, so you have to remember that there is an entity called as ANA negative lupus. That is why all ANA positivities is not SLE. There can be an ANA negative lupus and ANA can be positive even in normal healthy individuals. Okay, so ANAs are seen in 98% of the individuals of SLE, So thereby this acts as the best screening test. So it is not a diagnostic test for SLE, rather it is a screening test for SLE. Okay. So immunofluorescence is the best standard test. It is not ELISA, it is always indirect immunofluorescence techniques, and titers of 1:80 or higher may be clinically significant, right? So it has a good sensitivity, but it does not have a good specificity. Okay, so this is the best screening test. So ANA is the best screening test for SLE. Right. So the next antibody in SLE that we should be aware of is the anti-dsDNA antibody, which is seen in 70% of the individuals of SLE. Okay, DS stands for double-stranded DNA. Okay, so remember that dsDNA is highly lupus specific. High titers are highly SLE specific. Okay, and they correlate with disease activity. Right, so this is a most important point. It correlates with disease activity and it is associated with an increased risk of lupus nephritis, increased risk of lupus associated vasculitis. Okay, fine. So this is associated with higher specificity. It is used for disease activity monitoring. In fact, it's associated with a higher risk of lupus nephritis and vasculitis. So that is dsDNA. The third antibody is your anti-C1q, which is your early complement. Okay, so this can be present in up to 30% of the individuals associated with lupus nephritis, especially active lupus nephritis. Okay, so which antibodies are associated with lupus nephritis? One is anti-dsDNA, other is anti-C1q. Then we have your anti-Smith. Anti-Smith, though it is found in only 25% of individuals with SLE, if it is present, it is highly specific for SLE. Okay, so apart from dsDNA, if anti-Smith is present, then it is highly specific for SLE. Then we have anti-ribonucleoprotein, which are basically proteins which are complex with U1 RNA. This anti-RNP is not specific, but it is associated with overlap syndromes. Overlap means what? Overlap with other connective tissue disorders like rheumatic syndromes, and it is more common in blacks and it correlates with interferon induced gene signature. Basically, it correlates with the fact that there is a lot of interferon alpha signatures. Okay, so that is RNP. Anti-RNP is associated with overlap syndromes. Then we will look at anti-Rho and anti-La, which is seen in 30 and 40% of the individuals respectively. Anti-Rho and anti-La are not specific, but certain important points that you have to remember is that it is associated with a secondary Sjogren's syndrome. It is usually associated with a secondary Sjogren's syndrome, and it is associated with a type of skin manifestation of lupus, which is a subacute cutaneous lupus, SCLE, subacute cutaneous lupus. So when we look at the skin manifestations, we have acute, subacute and chronic cutaneous lupus. So subacute cutaneous lupus is associated with anti-Rho, and then it is associated with neonatal lupus with congenital heart block. Very, very important point. So it predisposes to congenital heart block in infants. So if there is a pregnant mother who has an anti-Rho lab positivity, remember that there is a risk of congenital heart block in the infant. And this is associated with a decreased risk of lupus nephritis. This is associated with a decreased risk of lupus nephritis. So remember, secondary Sjogren's syndrome, subacute cutaneous lupus, decreased risk of lupus nephritis. Okay, so there is a decreased risk of lupus nephritis. So that's about your anti-Rho law. Then anti-histone. Anti-histone antibodies can be seen in 70% of the individuals, and remember the catchword here is associated with drug-induced lupus nephritis more than SLE. Antihistone can be present in SLE, but there are a group of drugs which are associated with drug-induced lupus. Okay, so this is more common in drug-induced lupus. Then other antibodies, APS, antiphospholipid antibodies, seen in 40% to 50% of the individuals, and this means that there is a high risk of thrombosis. Okay, anti-erythrocyte antibodies, which is measured in direct Coombs test, it is associated with hemolytic anemia. Antiplatelet antibodies is associated with ITP. Then we have anti-neuronal antibodies which are associated with CNS lupus. So especially if it is a positive test for neuronal antibodies in the CSF, it is associated with active CNS lupus. Then we have ribosomal P antibodies, and this usually associated with depression or psychosis, especially neuropsychiatric SLE. So anti-ribosomal P is neuropsychiatric SLE. Okay, so this table may seem a bit confusing, but I have highlighted the most important catchwords that you have to remember about these antibodies. But it's very, very important that you remember all these antibodies and their associations, because each of this has a specific implication. Okay, so just to revise, anti-ROLA associated with decreased risk of lupus nephritis. It is associated with increased incidence of subacute cutaneous lupus erythematosus, risk of neonatal or congenital heart block, and secondary Sjogren's syndrome. The two antibodies associated with an increased risk of lupus nephritis is dsDNA and C1q. Most specific is anti-Smith. Then you have histone with drug-induced lupus, and then you have neuronal and ribosomal P. Neuronal is CNS lupus, ribosomal P is neuropsychiatric SLE. Okay, clear? So this is about the various antibodies which you can see in SLE. Then, what are the biomarkers for disease activity in SLE? So what do you mean by that? We are trying to understand that once the patient has SLE, can you use certain markers to prognosticate them and to see how they are behaving, right? So when they come for follow-ups, what are the biomarkers, which antibodies you can use to monitor the disease activity? So that includes anti-dsDNA. So you can send dsDNA titer levels to try and understand what is the disease activity in them. Then complements, remember always that SLE is associated with low complements, right? So if the complements are low persistently, that means that there is ongoing disease activity. Remember, there is a raised ESR but a low CRP. So remember that there is a raised ESR but a low CRP. Okay, so CRP will not be raised. So that is about the biomarkers for disease activity in SLE. Another very important point that we should be knowing is which are the drugs that are associated with lupus. Okay, so drug-induced lupus. What are the drugs? So you remember SHIP group of drugs. Okay, so this is sulfonamides, hydralazine, INH, procainamide, and methyl dopamine. So these are the drugs which are associated with drug-induced lupus. Okay, clear. Now let us move on to the entry criteria for SLE, which is called as the SLIC criteria. So SLIC criteria is basically a classification criteria which is making us understand whether there is a probability of SLE or not in this patient. Okay, so SLIC stands for Systemic Lupus International Collaborating Clinic Criteria for Classification of SLE. Okay, so if the SLIC criteria are satisfied, it does not mean that the patient definitely has SLE, but it is a classification criteria. So presence of any four of the criteria has a 92% sensitivity and a 93% specificity for the diagnosis of SLE. Okay, so SLIC criteria has two domains. So you look at the clinical manifestations and the immunologic manifestations. So you look at the clinical criteria as well as the laboratory criteria. So what are the clinical criteria? So we know that SLE affects any part of the body. So skin, it can be in the form of acute or subacute cutaneous lupus, or it can be a chronic cutaneous lupus, presence of paniculitis, right? Oral or nasal involvement in the form of oral ulcers or nasal ulcers. Non-scarring alopecia, synovitis involving two or more joints, presence of serositis, pleuritis, pericarditis, renal involvement in the presence of RBC CAS, proteinuria, neurologic involvement, seizures, psychosis, mononeuritis, neuropathies, and hematologic involvement, hemolytic anemia, leukopenia less than 4,000 or lymphopenia less than 1,000, thrombocytopenia less than 1 lakh. So presence of any one of this criteria, and one has to be a clinical criteria, one has to be a laboratory criteria. So any four, if they are there, then 92% sensitivity and 93% specificity. So what are the immunologic criteria? Definitely an ANA, anti-Smith, APS, low complements, and a direct comb test. ANA, anti-Smith, low complements, and direct comb test. Okay, so out of the 4, one has to be a clinical and one has to be a laboratory parameter, but if any 4 are present, then you can safely say or you can classify the patient as probable SLE. Alright, clear? So before this is basically jotting down what are the criteria, but to understand this you should be having a thorough knowledge of the laboratory parameters and a thorough knowledge of what all clinical manifestations can happen in SLE. So that is what we will be looking at now. So coming to the clinical features or the most important and interesting part of this chapter, right? So the most common clinical manifestation in SLE is the presence of constitutional symptoms. The presence of constitutional symptoms. Okay, so the most important clinical feature is the presence of constitutional symptoms, which is the most common clinical feature as well, in the form of low-grade fever and fatigue or malaise. Okay, so low-grade fever, fatigue or malaise, which is going on from a long time, is an important clinical manifestation, right? Then, what are the cutaneous manifestations? The cutaneous manifestation of SLE can be acute, it can be subacute, and it can be chronic, right? So acute, or the most classical thing that anybody can remember, is the presence of a very characteristic rash that we call as the malar rash or the butterfly rash. Okay, so I'll just enlarge this for you here. So can you see that there is a rash which is involving the malar area, and this is similar to a butterfly, correct? So there is a rash involving the malar area similar to the butterfly, and this is what we call as the butterfly rash of SLE. And remember that this malar rash is a highly photosensitive rash. Okay, so this malar rash is a highly photosensitive rash. That means when there is exposure to sun, there can be worsening of the rash, and very characteristically it spares the nasolabial folds. Okay, it spares the nasolabial folds. So there is no involvement of the nasolabial folds in the malar rash of SLE, and an important differential diagnosis is what we called as acne rosacea. So this acne rosacea will involve the nasolabial fold, whereas malar rash will not involve the nasolabial fold. Okay, so this is your characteristic butterfly rash of SLE. Apart from that, you can have a morbilliform rash, or you can even have a toxic epidermal necrolysis like feature which has the presence of various bullous rashes. So bullous rashes can also be seen as a part of TENS. Okay, so you can have bullous rashes, you can have morbilliform rash, you can have malar rash. These are different rashes which you can see in acute cutaneous lupus erythematosus. Then in subacute form of cutaneous lupus erythematosus, which is called as SCLE. Remember, it has what associations? HLA-DR3 and anti-Rho. Okay, so these lesions can either be annular, or you can have psoriasiform like lesions or psoriasis like lesions, and these usually spare the face. Okay, also another point about this morbilliform rash in acute cutaneous lupus erythematosus, this can spare the knuckles. Okay, this annular and psoriasiform lesions can spare the face. Then chronic cutaneous lupus erythematosus, in your chronic forms, this type of rash is what we call as the discoid rash. Okay, so this has a central clearing. As you can notice here, this has a central clearing, and this is usually associated with a scarring. Okay, it can be commonly found in the face, it can be found behind the ear, it can be found over the scalp as well, right? So this has a central clearing, it is associated with scarring, and this is what we call as a discoid rash. And this type of appearance, you can see that in the center there is some clearing, and this is what we call as the carpet tack appearance. So where do you find carpet tack appearance? It is seen in chronic cutaneous lupus erythematosus or your discoid rashes. And remember that this is a pre-malignant condition. Acute and subacute are not pre-malignant. This is a pre-malignant condition and there is an increased risk of squamous cell carcinoma of the skin. Okay, so this is about your acute, subacute and chronic cutaneous lupus erythematosus. Fine. Okay. Then there can also be some certain lupus non-specific skin lesions which can be found in patients with SLE. So what are the lupus non-specific skin lesions which can be found in SLE? So we have chilblain lupus. Chilblain lupus, which basically refers to, so if this is your feet, you can have little bit of desquamative lesions over your toes, and this is what we call as chilblain lupus. Then there can be lupus paniculatus or lupus profundus. Lupus paniculatus basically refers to the inflammation of the fat pad which is present in the subcutaneous plane. So these are your lupus non-specific skin lesions, right? So remember malar rash, remember subacute SCLE and chronic forms of cutaneous lupus. Next we come to the musculoskeletal manifestations of SLE. So SLE can present with a chronic history of joint pains. Okay, and the basic pathophysiology is that there can be evidence of synovitis, which means inflammation of the synovium of the joint. But the type of arthritis that you can have, so you can have arthralgias, joint pains are nothing but arthralgias. You can have arthritis, but this arthritis is a non-erosive type of arthritis. But this is highly different from rheumatoid arthritis, which is an erosive type of arthritis. So here you have a non-erosive type of arthritis, and this is what we call as the Jacquard arthropathy. Jacquard's arthropathy. Okay, so in SLE you can have a non-erosive arthritis which is called as Jacquard's arthropathy, which occurs due to the laxity of ligaments, So can you see here that there are deformities, right? So you might think or confuse this to be an RA, right? But this is your Jacquard's arthropathy, which basically occurs due to laxity of ligaments. It's a non-erosive type of arthritis. Okay, fine. Then what are the cardiovascular manifestations of SLE? Remember that the heart of an SLE patient is actually 10 to 20 years older than your normal age. So in fact, if you see that normal individuals get atherosclerosis by 50-60 years of age, and a patient with SLE, because of this background chronic underlying inflammatory process that is going on, they can develop atherosclerosis at much younger age groups. Their heart becomes much older. So always remember, atherosclerosis is a risk factor, and in fact MI is one of the most common cause of death in SLE. So always be very careful, screen the patient for all risk factors, screen them for diabetes, hypertension and dyslipidemia, and empirically treat them with statins and so on. Right? Now SLE can be associated with antiphospholipid antibody syndrome or your antiphospholipid syndrome, which is your APS, and hence they have an increased risk of thrombosis. So this thrombus can affect the lungs, it can affect the heart, so you can have pulmonary thrombus, you can have MIs as well. SLE can also be associated with inflammation of the vessels. So this can result in a small vessel vasculitis as well as a medium vessel vasculitis. Small vessel vasculitis can result in skin lesions, what we call as purpura. Medium vessel vasculitis involves the vessels of medium caliber. So it can involve the GI tract or it can involve the CNS. So CNS can result in CNS vasculitis, which can result in strokes. In GIT, it can result in GI bleeds or it can result in mesenteric ischemia. Okay, so this is about the cardiovascular manifestations. Then pericardium. In the pericardium, what is the most common manifestation in SLE? You can have pericardial or pericarditis with or without effusion. Okay, you can have pericarditis or you can have the presence of massive amounts of pericardial effusion. And in the endocardium, you can have sterile vegetations. You can have sterile vegetations, and this is what we call as Liebman-Sachs endocarditis. Liebman-Sachs endocarditis. Right? So this is about the various cardiovascular manifestations of SLE. And then In the lungs, how is SLE going to affect the lungs? The parenchyma is usually spared, and the most common manifestation of SLE in the lung is pleuritis, with or without pleural effusion. So pleuritis is the most common manifestation in the lungs. But if there is some amount of vasculitis which is going on along with your SLE, then there can be damage to the alveoli, and there can be something called as diffuse alveolar hemorrhage. This is called as DAH, which is diffuse alveolar hemorrhage. And the presence of diffuse alveolar hemorrhage is a very poor prognostic factor. They present similar to an ARDS kind of picture, and they can present with massive hemoptysis. So diffuse alveolar hemorrhage can result in an ARDS kind of picture and can present with massive hemoptysis. And how do you diagnose your DAH? Diagnosis of DAH, when you do a bronchoalveolar lavage, you will see the presence of hemosiderin-laden macrophages. So you can have hemosiderin-laden macrophages. Okay, then GIT, what will you see? Predominantly hepatic, and you can have autoimmune hepatitis, which is called as lupoid hepatitis. So the type of autoimmune hepatitis that you find here is the lupoid hepatitis, right? So usually the GI tract is spared unless there is an underlying vasculitis, and the hepatitis that you get is a lupoid hepatitis. Then the central nervous system. What will you find in the central nervous system? The most common manifestation amongst the central nervous system manifestations of SLE is your cognitive dysfunction. But if there is a CNS vasculitis, it can result in strokes. Then in the peripheral nervous system, what will you find? In the peripheral nervous system, you can find evidence of neuropathies like a mononeuritis multiplex. Okay, fine. Then hematologic manifestations, you can have hemolytic anemias. Then apart from hemolytic anemias, what can you have? You can have lymphopenia, you can have leukopenia, you can have ITP, idiopathic thrombocytopenic purpura, or severe forms of thrombocytopenia. Okay, right? You can also have thrombotic thrombocytopenic purpura, which is very dangerous. Right, in those cases, you can have rapidly progressive renal failure and the presence of schistocytes in the peripheral smear. Then we have the macrophage activation syndrome. Macrophage activation syndrome, or MAS, where there can be severe immune dysregulation, and the highlighting features of macrophage activation syndrome is cytopenias, fever, organ dysfunctions, splenomegaly, low ESR, high triglycerides, high ferritin, and high interleukin-2 receptors. So this is basically similar to your HLH, hemophagocytosis, lymphohistiocytosis, where there is emperopolysis. If you do a bone marrow examination, there is a cell within a cell. Okay, so the macrophages begin to eat up all the cells, resulting in severe organ dysfunction. So there is cytopenias, there is organ dysfunction, fever, splenomegaly, low ESR, high triglycerides, high ferritin, and high interleukin-2 receptor levels. Okay, so this is about the various hematologic manifestations of SLE. Now let us move on to lupus nephritis. Now let us understand the next clinical manifestation, that is lupus nephritis. So this is a very important manifestation, which is lupus nephritis. Okay, so lupus nephritis can be classified into 6 classes. So the first class is the minimal mesangial lupus nephritis, where you do not have any clinical manifestation, and the histological description is that there can be mesangial immune deposits. So most often in class 1 lupus nephritis, you do not have any clinical manifestation. You do not have proteinuria, you do not have RBC CAS, you do not have hematuria. Okay. Then class 2 is mesangioproliferative, where you can have microscopic hematuria or proteinuria, sometimes hypertension. So as the name suggests, here you have mesangial hypercellularity or mesangial matrix expansion with few subepithelial or subendothelial deposits. So class 1 and 2 are usually safer forms of lupus nephritis, where you do not require any treatment, and if hypertension is there, you can manage it with ACE inhibitors or ARBs. Then class 3 and class 4. Class 3 refers to focal and class 4 refers to diffuse. Okay, so they can be focal deposits or they can be diffuse deposits. Okay, so how does it present? It presents with hematuria or proteinuria. So every time a lupus patient presents to you, you have to screen for evidence of lupus nephritis involvement. So this is characterized by hematuria and proteinuria. Okay, so if less than 50% of the glomeruli are affected, then it is a focal segmental glomerular sclerosis, or you can have a diffuse segmental glomerular sclerosis. So can you see in this image in the histopathological examination, there is segmental proliferation wire loop lesions. Okay, so you can have segmental lesions. This is your focal deposits. And in the electron microscope, you can see that there is evidence of mesangial deposits and immune deposits in the mesangial area as well as in the subendothelial space. Okay, in diffuse, what happens is frequently it is a nephrotic type of proteinuria and there is more than 50% involvement of the glomeruli. And sometimes you can also have formation of, can you see here, this crescents, right? So crescents is having a very poor prognosis. You can have a collapse of the glomeruli and expansion of the parietal epithelial cells resulting in crescents. So this can present as rapidly progressive renal failure. So class 3 and class 4 lupus nephritis can present with rapidly progressive renal failure, and this is characterized by subendothelial deposits, which you can see here. You can see subendothelial deposits. Okay, fine. So this is about the class 3 and class 4. Then class 5 lupus nephritis is called as the membranous, where this presents predominantly with a nephrotic range proteinuria. There is a nephrotic range extensive proteinuria where you can have granular, global or segmental subepithelial deposits. Okay, so in membranous type, class 5 is similar to your membranous nephropathy, where you have thickening of capillary loops, you can have a tramp track appearance, you can have subepithelial deposits. Okay, so you can see that there are thickened capillary loops without proliferation within the mesangial areas. Okay, so this is your thickened capillary loops. Fine, and you have subepithelial deposits. So these are the subepithelial deposits which you can see here. This is the subepithelial deposits. Then your class 6 lupus nephritis, there is advanced sclerosis presenting as CKD where more than 90% of the glomeruli are involved. So this is about the various classes of lupus nephritis. So what are the indications for biopsy in a patient with lupus nephritis? If you are suspecting, when will you do a biopsy? If the UPCR is more than 0.5, okay, so if the UPCR is more than 0.5 or there is presence of RBC cast, then you have to suspect a class 3 or class 4 and subject them to a renal biopsy. Clear? So this is about lupus nephritis. Now let us go on to the management of systemic lupus erythematosus. Okay, so first you have to see whether there is a symptom complex which is suggestive of SLE. So presence of a rash, presence of fatigue, presence of arthralgias, presence of cytopenias, raised ESR. Okay, so these are the ways in which you will suspect lupus. Then you look for the laboratory test, which includes an ANA, CBC, platelets, a urine analysis to rule out lupus nephritis. Then if the tests are normal and symptoms persist, then you may have to do a repeat ANA. Now if the ANA is positive, you see if it is a definite SLE or a possible SLE. A definitive SLE is when you do your SLIC criteria and the criteria are more than 4 in number positive, it is definitive SLE. If it is less than 4 in number positive, then it is a probable SLE. That is when you will have to initiate the treatment. To initiate the treatment, you have to see whether there is life-threatening organ involvement or there is no life-threatening organ involvement. If there is no life-threatening organ involvement, then you do a slightly lower down dose of glucocorticoids. So you give them low dose systemic glucocorticoids. You may consider Belimumab or anifrolumab. These are basically certain newer immunomodulatory agents. So low dose glucocorticoids as well as HCQ. So low dose glucocorticoids as well as HCQ is used in non or life threatening organ involvement. Like for example, you have only a skin involvement or you have only a joint involvement. then you give them low dose glucocorticoids with HCQ and you monitor them. Now, if there is a life-threatening organ involvement, then the patient will require a high dose glucocorticoids and a secondary agent. So most of the time we give IV methylprednisolone, and this is what we give as the pulse therapy. Okay, so we do something called as the IV methylprednisolone pulse therapy, where 500 mg to 1 gram is given. Okay, and then you change it to oral and you taper it over some time. Okay, with the addition of a secondary agent. The agents used are MMF, a cyclophosphamide, or in lupus nephritis the treatment is completely different, that we will see. Okay, if there is a response, then you taper the dose of the immunosuppressions, especially the glucocorticoids. If there is no response, the other drugs like Belimumab. Belimumab is basically a BAFF inhibitor, or rituximab, calcineurin inhibitors are the other drugs which can be used in SLE. Okay, so let us understand the management of lupus nephritis because it is slightly different. So, how do you manage a class 3 and 4? Class 1 and 2 would just require maximum of an ACE inhibitor. Class 3 and 4 lupus nephritis management is slightly different. So, you have to give an IV pulse methylprednisolone, which is given at about 500 mg to 1 gram, along with a secondary agent which is around, which can either be a mycophenolate mofetil, which is MMF of 2 to 3 gram per day, and this treatment will go on for at least 6 months. If MMF is not used as a secondary agent, the other agent that you can use is cyclophosphamide. Okay, so there are 2 regimens which you can use along with high dose glucocorticoids, pulse therapy. Along with this, there can be 2 regimens of cyclophosphamide that you can use. So you have a high dose regimen of cyclophosphamide, which is called as the NIH protocol, where you give 500 mg to 1 gram per meter square monthly for 6 doses. Or you can go a low dose regimen, which is called as a Eurolupus regimen, where 500 mg IV is given every 2 weeks. Okay, so this is how you manage your class 3 or class 4 lupus nephritis. You give pulse steroids along with MMF or pulse steroids along with cyclophosphamide. Cyclophosphamide can be given as 2 regimens, either of the two, NIH protocol or Eurolupus regimen. NIH protocol is your high dose regimen, Eurolupus is your low dose regimen. Okay, but in class 5, the treatment of class 5 lupus nephritis is slightly different. Here you give oral prednisolone of 0.5 mg per kg per day for 6 months along with MMF of 2 to 3 gram per day. Okay, so that is your class 5. So here the major difference is in class 5 you may not require a pulse steroid therapy. What are the adjunctive drugs that can be used? You can use HCQS, use ACE inhibitors, you have to tell your patients to stop smoking, and you have to use statins. Okay, so this is about the management of lupus nephritis. Now, what are the other principles in the management of SLE? Always remember about photoprotection. Especially if they have skin involvement, always administer photoprotective agents. Ask them not to venture out in the sun, wear a cap, wear certain emollients which are photoprotective agents. Always remember to treat the underlying comorbidities, because SLE is a huge predisposition factor for early onset atherosclerosis. So always look at your diabetes, hypertension, dyslipidemia. So this ensures that there is no further progression of your lupus nephritis as well. Then prevention of osteoporosis. Prevention of osteoporosis is also very important, because long-term glucocorticoid use is associated with a high risk of osteoporosis, high risk of osteoporosis related fractures. Also, there is an increased risk of avascular necrosis of the femur. Okay, so please do monitor for your bone mineral density, especially if they have been on large doses of glucocorticoids, and you prevent falls. You provide them with vitamin D and calcium supplements. Then prevention of infections is a very important part of SLE management. Why? Because immunosuppressive agents predispose the individual to infections. So ensure that they are well vaccinated. They are well vaccinated. And what are the vaccines you want to give them? You want to give them an annual influenza vaccine. Okay, you want to give them a pneumococcal vaccine. In elderly, you want to prevent them from varicella zoster, so you will have to give them a shingles vaccine as well, and you give them your DTaP vaccine. Okay, so ensure that they are adequately vaccinated. Then, especially if you have an SLE patient with APLA syndrome, with an APS syndrome, then you have to prevent clots, and hence you may have to start them on anticoagulants. Okay, so this is about the various other principles which are used in the management of SLE. So with this, we have come to the end of our chapter on SLE. Thank you.